Hello, Sam.
Dr. Kinoshi?
Yeah, I don't see Dr. Oh, there's Dr.
Yes.
Miseer. Dr. Miseer, are you back? Dr. Miseer? I see we've got only 3 minutes. Now it gives me the jitters. Let me give him a call.
Yeah.
Before you let people, before you let
Before we let everybody in.
I couldn't get Dr. Sheen's. Miseer. Hello, Dr. Miseer. I was trying to give. Okay, can you unmute him, Sam? It says it needs host to unmute him. Make him co-host as well, Sam. Yeah. Okay, just keep on the line.
Okay.
Sam, can you hear me?
Yes, I made him co-host. He now has full hosting.
Perfect.
That's right.
Yeah.
Okay.
Yeah.
Okay. Are you in now, Dr. Miseer?
Awesome.
Yes, perfect.
Yeah. Okay. Just
don't worry, I won't give you jitters.
No, that's fine. I was getting jitters. The volume is a bit low, Sam. Is that fine on your side?
I think maybe when he presents, he can just project better. I think it's just a matter of projection. Yeah.
Sure. Is that loud enough?
Yeah. Okay, just say something again, Dr. Miseer.
So the neuropsychiatric manifestations of TBI?
Yeah, okay. Yeah, a little bit higher.
A little bit higher.
Can do.
Do you want me to
closer?
Let me try it with earphones. Maybe that'll make the difference. Because I've noticed that with the earphones.
Sam, are you all right with your sound on your side?
Yeah, I think I'm all right because I'm wearing headphones. So
Oh yeah.
Let me do this.
Dr. Miseer, you can leave the headphones. I think people will hear.
Okay.
Yeah, I think you just maybe closer to your laptop or this thing. But
I'll go closer.
That's right. I think it sounds much better. Thank you very much. So I think I just want to close my door. Then you ready to let them in?
Yeah, you're already sitting. Dr. Kinoshi?
Yeah, I was saying, are you ready to let people in? It's 6 o'clock. Yeah. Okay, all the best, Dr. Miseer.
Thanks, Dr. Kinoshi.
Okay, I'm letting everybody in.
Okay, thank you. Yeah, we have 3 people already, so we can let them in. Okay. Good morning, everyone. Good afternoon. Good afternoon, everyone who've already joined in. We're still letting people, we still have a lot of people in the lobby, but I see it's already 1 minute past 6 p.m. and we already have 166 people still coming in. But letting people in, we will start. I am Dr. Ernest Kinoshi. We are working position here as in operations with Clinix Health Group. Clinix Health Group is it's one of the players in the private healthcare sector, runs 8 hospitals at the moment, 5 acute care hospitals, 2 mental health hospitals, and 1 day hospital in the Johannesburg City Center. So I think it's a mature group that has been around since 1992, pre-New South Africa, if you like. And it has grown and expanded, and also has kept up to developments in our country, in our healthcare system. And I think it's a major player, especially amongst the historically disadvantaged populations, where we want to increase access to quality healthcare for all. I think that's what in Clinix's group is we take it as a mission. As one of our missions is to do that. Clinix Health Group has been running these online webinars since the advent or the onset of COVID in 2020, and they replaced previous CPD in-person sessions that we used to run. But because of lockdowns, level 5 lockdowns, we had to move to something else, and we tried online webinars, and we thought just for the period whilst there's still COVID, but post 2023, we still had a lot of demand from yourselves, people who participate every week after week. So we just continued. I think we are grateful to the board and to the board of directors, and also to the executive of Clinix Health Group for continuing to sponsor these webinars, bringing them free to all healthcare workers who would like to expand their knowledge, learn from the experts. And also we are grateful to the experts who give of their free time to prepare these talks that we give every Thursday, free of charge. And I know we give a token of gratitude after our speakers have spoken. We always do that, but basically they are free of charge to yourselves, but also to the speakers themselves. So except for the token of gratitude, as I've said. We say these things every week because we get new participants attendance every week, so we have to update them as well. I think we also have negotiated with SAMA and also with HPCSA for CPD points, HPCSA CPD points. So every time anyone registers for our webinars, you automatically, your CPD point profile with HPCSA gets updated automatically. HPCSA used to give us certificates, which we used to send, on your emails to yourselves to register with the HPCSA, the points. But now everything is so fine and digitalized. HPCSA, just as you register, we then you remember when you registered, you had to give your name and HPCSA registration number. I think that's crucial. And after your attendance, only those who attend, of course, we then confirm with them, HPCSA, yes, Dr. So-and-so or Ms. So-and-so, Mr. So-and-so did attend. Then they update your CPD point profile. I think all of you do get the HPCSA emails now and then with the latest profile. And if your profiles are not updated, at least 4 weeks after attending any of the Clinix webinars, please let us know so that we can follow it up. HPCSA should update your CPD points profile within at the most 4 weeks. Usually they take a week to 2 weeks to update it. You can let us know by writing to us on webinars@clinix.co.za. clinix.co.za. Webinars@clinix.co.za. We have our speaker today. As the speaker proceeds with his presentation, we will mute everyone. I'll mute myself as well, and but you will be able to write your questions, type your questions or comments in the chat box. So anything that you want to write, you can write anytime in the chat box. We will attend to them. Our speaker today will attend to them at the end of his presentation. We will also let you raise your electronic hand at the end of his presentation. If you'd like to make your comments or you would like to ask your question orally, we'll be able to do that as well and interact. Our speaker today is Dr. Prinesh Miseer, as you can see on the screen. Dr. Miseer is a psychiatrist. He obtained his MBCHP from Witwatersrand, University of Witwatersrand Wits, and he also went on to do his, he attained his MMed in psychiatry from Wits as well. And of course, he also did his FC Psych with the Colleges of Medicine of South Africa. He's a subspecialist in neuropsychiatry, and I think he'll tell you more about it. So we could say neuropsychiatrist. He's got special interest in neuropsychiatry. He's currently working. Is a joint appointment between Gauteng Department of Health and University of Witwatersrand. He works in the district health specialist team, in the Johannesburg district health specialist team, but he also is a lecturer in psychiatry at Wits. He's the chair of the SASOP Neuropsychiatry Special Interest Group, and he maintains part-time private practice as well, both in Soweto, but also in Clinix, Solomon Sticks Morewa Memorial Hospital, which is, I think, one of the bigger ones, the bigger mental health hospitals in the private sector. The hospital has got almost 600 mental health patients at the moment. So by private health standards, it's quite huge. So he's got a private practice then over and above all what he does. His special interest includes autoimmune illnesses, neurodegenerative disorders, and functional neurological disorders as well. He is dedicated to advancing the field of neuropsychiatry by expanding clinical services and training future subspecialists also to meet the growing needs of local communities. Dr. Miseer, I think over to you. I'll mute myself now and you can go on with your presentation. I'll come back when you're done. Thank you very much. All the best.
Thank you so much, Dr. Karashi. And thanks to the Clinix Health Group for allowing me this chance to, deliver a message around neuropsychiatry and just with regards to some of the, areas in the speciality that, are not really generally known. And it is also Mental Health Awareness Month, so that's primarily the reason why I was asked to do this presentation, but let's get straight into it. And I think it's something that really encapsulates neuropsychiatry is traumatic brain injury. And I added it in for interest, just a brief focus on chronic traumatic encephalopathy, because it seems to be quite topical, especially with our rugby players and the amount of concussion sustained and post-concussive syndrome, just an idea of how we as neuropsychiatrists see some of these patients. So going ahead, what we generally know about traumatic brain injury is that it always refers to brain damage. It's usually blunt force, It's most often mechanical or blast, and usually bilateral. You can also have penetration, and that ultimately results in direct destruction of the brain. But in order to define a traumatic brain injury, there has to be the presence of neurological or neuropsychiatric symptoms, and that encapsulates a cognitive change or behavioral deficits or changes. And the intracranial pathology is needed for the establishment of the traumatic brain injury itself, and for you to be able to say that there are some issues. Briefly, the epidemiology of traumatic brain injury. We do know that there's 69 million individuals worldwide that sustain a traumatic brain injury. And in our country, like most other low middle income countries, we are faced with this issue regarding assault and motor vehicle accidents and gunshot injuries. And essentially, we are at the high end of the spectrum in terms of prevalence and incidence. According to a Netcare report, we do have one of the leading causes of disability in South Africa being traumatic brain injuries, and it's estimated that 89,000 new cases of TBI are reported every year in the country. So we do see that clinically. We see that in our hospitals, just how prevalent it is, and what a burden it is on the healthcare system in terms of all the different disciplines that are involved in this care. And a lot of you will be familiar with just the common causes of traumatic brain injury. And as I said, what's become more topical is in regards to sports injuries. And with our Bokke doing so well, I think we start to realize just how difficult some of these injuries can be, and in terms of their management. So what we have to do is that, but I will go through that a little bit later. But just to give you an idea that that's become a little bit more in vogue. The mechanisms of brain trauma, you have these acceleration, deceleration forces that causes shearing of the axons, that are causing this nerve damage. And, essentially you have these injuries that can be described as contra coup. So you have an injury in the initial area, and then the rebound injury is felt, further on. So you do have these different mechanisms that can cause the brain trauma. So as I said to you, we are 4 to 5 times the global average in terms of just with regards to motor vehicle collisions and interpersonal violence. So you can understand why our traumatic brain injury average, sub-Saharan wise, is a little bit more than the global average. And the vast majority of patients are admitted with mild traumatic brain injury, and that's using our Glasgow Coma scale. So this is just some of the research that's come out. There's always two age-related peaks. We have a young age group that's mostly motor vehicle accidents, and the elderly, whereby the mechanism is falls. You have a male gender predominating worldwide. Unfortunately, we are more predisposed to be hit on the head. And socioeconomic status, lower socioeconomic status is one of the factors. And the issue obviously in South Africa, which we've also seen clinically, is our alcohol use, and that obviously is a concern and has many kind of effects in terms of indirect and direct with regards to traumatic brain injury, and even people developing substance use issues. But we'll discuss that a little bit further on after TBI. So just in terms of classifying traumatic brain injury, there is this controversy over what is concussion, post-concussive syndrome. Are we all speaking the same language? And I think it's very much also an American issue versus an international issue, because, in terms of, even when you look at, there's a film with Will Smith that discusses, it's named Concussion, but actually that movie is about chronic traumatic encephalopathy. And it doesn't really kind of define it if you just had to look at the name of the film. But we are unfortunately grappling with regards to all these different terms and the uniformity of these terms. But I mean, the one thing that we've started to realize is that there's a way to classify it. We've got something that within our own country, the neuropsychiatrists use, and I'll go on to it just now. And then in neurology, it's further classified as a focal injury or diffuse traumatic brain injury. So just in terms of that table, I mean, it comes mostly from the military veterans, the US military veterans scale, and it's quite a good way of classifying traumatic brain injury and, kind of structuring the severity. But the truth is that there are, when I used to study this in terms of traumatic brain injury, there's almost 50 to 100 scales that you could use. There's numerous scales that have been developed and researched and validated. So the one thing, though, that we found was quite useful with this is especially the loss of consciousness and the post-traumatic amnesia. We all know that the Glasgow Coma Scale can be sometimes a little bit unreliable, especially regarding who's documenting it and who's creating that examination in order to determine that score. But if you look at the severe end of loss of consciousness and post-traumatic amnesia, more than 24 hours and more than 7 days immediately becomes severe. And you also take in structural imaging, and you can see that even with a brief period of loss of consciousness, 0 to 30 minutes, you immediately are falling within the traumatic brain injury criteria, into the mild traumatic brain injury. And this is just another classification that has been developed. I'm not going to focus too much on that. So where do we come in as neuropsychiatrists? Because I mean, we're trying to create this blend between the neurological insult and understanding that there are going to be psychiatric manifestations that occur post any neurological insult, whether it's neurodegenerative, whether it's due to an infection. The point is that this is where we're trying to almost unify the response that every illness of the brain is going to have these three major kind of symptom categories. And this is what we've been trying to push in terms of for our own profession. And it's a way that we can effectively screen and get an effective history in terms of what exactly is going on in the brain. So we have divided it up into neurological symptoms, neurobehavioral symptoms, and neurocognitive symptoms. Of course, we're dealing with patients who are post in terms of the coma and the minimal level of consciousness. So we are dealing with patients who have now woken up and are beginning their rehab, and they start to have these kind of manifestations. So in terms of discussing chronic neurological symptoms, let's start with that. The one thing that you have to be very careful with these patients, and we've experienced, is that you have to be able to almost create a list of all the symptoms that the patient is going through so that you can address each one of them and target their management. Otherwise, it results in certain kind of issues. Specifically, post-concussive syndrome is one of them. And this is why it's quite an exhaustive list, but it's important for everyone to know that these symptoms do exist. And this is what we try to mitigate in terms of when we're creating a management plan. Headache would be quite a common one in mild traumatic brain injury, with a prevalence, depending on the studies, between 25 to 90%. And it's quite an acute onset within 2 weeks of injury, and it usually resolves in 2 months. It can also be chronic, and then we start to look at, kind of issues regarding the psychological state of the patient. And what we start to see is that we have used different kind of modes of treatment, but essentially using your anti-inflammatories, you can use some of the pain pathway targeting medications in terms of your carbamazepine and treponine, but these are some of the options that you have. Another under-recognized symptom is dizziness and nausea. It's the second most common neurological symptom. And, its central etiology involves the brainstem and vestibular nuclei in particular, and it may persist with moderate to severe traumatic brain injury. And we've seen this in patients that, report this dizziness. When it starts to become a bit more chronic, again, we start to look at things like post-concussive syndrome. And there's no clear treatment superiority, but it does show in the research that antihistamines and anticholinergics may show some benefit. Fatigue is a big issue because it ultimately determines, how the patient is going to interact in their social and occupational functioning. Well, obviously, initially it's the social functioning, getting back to their family, and it can be quite debilitating. The issue with fatigue is that it sometimes, unfortunately, is complicated by the fact that the patient's got ongoing pain symptoms, sleep disturbances directly from the traumatic brain injury or from the resultant comorbid depression that develops, and even the cognitive deficits and anxiety. It can also be confounded by medication use that's used in terms of, even your analgesia and some of our other medications that we use psychotropic wise. We have tried to use stimulants, methylphenidate, essentially Ritalin, and modafinil, which is a stimulant, and bromocriptine. Just with one word with regards to this, just to note is that unfortunately you've got to be careful sometimes with the traumatic brain injury and stimulants, because it can lower the seizure threshold, and then you start to complicate in terms of causing seizures. So look, it's something that does take a bit of time to resolve, but it does have that association with this poor quality of life. Directly in terms of sleep disturbances, not just speaking around sleep and depression or anxiety, we'll get to that, but it's quite common, and it's much more than in the general population. It's characterized by initial insomnia, this inability to maintain and restless sleep. daytime somnolence and parasomnias. It's not clearly linked to the severity of the TBI, and it's quite a complex etiology as to why it comes about. So it's poorly understood in that sense as to what is the direct reason for it. Seizures are of very big interest in terms of anything that's going to cause a direct injury to your brain. Is going to create a focus and ultimately abnormal electrical activity. And it may present early, within 7 days of the insult, and this is quite interesting, or late, anytime up to 15 years later. And this is what makes it a bit difficult in terms of, with regards to these patients, is that you can have such a late presentation, even 5 to 10% of these patients. It can be simple or complex depending relatively on the absence or presence of loss of awareness, and both can evolve into the generalized or the secondary seizure in terms of tonic-clonic presentation with your clear post-ictal symptoms. The frontal and temporal origin is the more usual, and that's usually of all epilepsies, but you do sometimes get an EEG negative in most cases. So the frontal and temporal regions are generally the most kind of vulnerable areas when it comes to traumatic brain injury in terms of when the brain is injured. So this is something that is poorly understood in terms of and doesn't get enough credit in terms of a symptom that the patient may experience, especially the neurological symptoms. And it's something that we've seen in patients who have gone through this entire episode of mild to severe traumatic brain injury, and they have these episodes of this extreme, almost sympathetic hyperreactivity. And a lot of the times it can be misdiagnosed as various other kind of issues in terms of even a seizure, or it can even be misdiagnosed as agitation. So it's something that you have to ask, and it's good that we're making people aware of it, because it's something that you must include in your history taking in order to determine if this is something that can be addressed. Endocrinological changes post TBI are also a major issue, and something that must be investigated, and something that must be kept in mind, especially with regard to the hypothalamus and pituitary injuries. We do see that because of the diffuse axonal injuries, and the fact that deceleration acceleration forces, those areas are vulnerable to those kind of forces. And it may not be evident for months to years that you may have this issue with regards to diabetes insipidus or hypothyroidism. And this is where you have to work in conjunction with the endocrinologist, check the thyroid and testosterone levels, because it's something that we do see in some of the patients with traumatic brain injury, and quite a few of them. So this is generally where we come in terms of helping, especially with the neurobehavioral, because I mean, this is most of the time how it manifests. And when I mean neurobehavioral, I'm talking about mood symptoms, psychosis, personality changes, essentially, some of the psychiatric symptoms that our general psychiatrists are more used to. And it's usually severe neuropsychiatric impairments post-TBI which present to psychiatrists with these unusual diagnostic and treatment challenges. And in terms of, unfortunately, pharmacological interventions directed at a post-TBI complication, it's a lot more that we've been using a lot more off-label, anecdotal, instead of actually having a body of evidence regarding, post-TBI mood disorders or post-TBI psychotic. So it's a lot of what we know already from mood disorders that we've just kind of taken and pushed onto this group of patients. But the issue with these patients is that they are a heterogeneous group of patients, and they come with a lot of different presentations depending on what their premorbid history was. So if you've got somebody with a premorbid psychiatric history or substance history, it changes the picture, but compared to somebody who doesn't have that. So this is quite a heterogeneous group of patients, and that's what makes them quite a treatment challenge. And also the actual severity of the traumatic brain injury already changes, that already dictates that the patient profile is going to be different. One of the most important things is this personality change. And it's something that we do see, and it's quite sad because, so, for example, one of the patients who used to come to the neuropsychiatric clinic at Baragwanath ended up, losing his ability to even be a poet, and he was a rapper, and he was on his way to being successful, and he lost that ability. And the family even noticed after the frontal lobe injury that he had become a little bit more coarse and unempathic. So these things do happen, and unfortunately, sometimes they don't actually get better, despite the brain being neuroplastic, and that time where there is some sort of healing happening. So it can be characterized again by that impulsivity, that irritability and lability, and it can also exacerbate an underlying psychiatric disorder. In terms of aggression, is quite a common one we've seen. Especially with regards to if there's pre-morbid mood or personality disorder and there's pre-existing substance abuse. There are ways to treat this. I think it'll come through in the next couple of slides, but it's quite common, and it's these outbursts. And it's similar to what we see sometimes in chronic traumatic encephalopathy. There is this quite clear post TBI aggression that occurs and needs to be treated because it can end up becoming, physical aggression, and it can lead to legal consequences. With regards to the frontal lobe syndromes, you do get this mixture of dysexecutive, disinhibited, apathetic, depending on where the actual area of the brain is hurt. And you can get a mixed picture too of mixed disinhibition and apathy. So patient is generally, disinhibited in terms of their behavior. They can be a bit stimulus or environmental bound in terms of if somebody puts something in front of them, they reach out and grab. So those frontal release signs are showing. And also that apathy, again, can be quite difficult in terms of for their functioning and their quality of life. So in terms of medication that we use for some of these behaviors, we've noticed that in SSRI, yes, it does cover the depression also, but also for those problematic behaviors, we see that it's almost the handbrake between the frontal lobe and the striatal area. So that network there allows us to be able, or that road between your frontal lobe and your basal ganglia allows you to almost be able to have that control of your disinhibition. But unfortunately, in a brain injury, that's what gets lost. And we find that the SSRI is able to help with regards to those networks. And it also helps in terms of the impulsivity and just to also help with that episodic aggression. Beta blockers have also been proven quite a bit in studies and shown potential utility, and we use it quite frequently in the clinics, and it has helped with regards to the frequency of these aggressive episodes. Excuse me. So antipsychotics, as much as you think that yes, we'd use an antipsychotic immediately, we actually don't. In terms of there is a bit of a higher morbidity and associated with antipsychotics and mortality, especially if somebody has had a severe traumatic brain injury. So we are using more SSRIs and beta blockers when it comes to that aggression, and we've found quite a bit of success. Not really too much mood stabilizers. So with regards to mood, and we're talking about now depression and manic presentations, major depressive disorder is very common, and that's for most of neuropsychiatric illnesses. You've got more of a mood presentation and anxiety that's more common. Mania and psychosis are rare. I was just saying this in another talk the other day that mania and psychosis are actually the reason why we always feel like those are more common is I guess because they present more often and it seems like as if they are amplified. But it's actually mood and anxiety or depression and anxiety that are the more common issues whenever the brain is undergoing any kind of issues or any injury. And it ranges in 25 to 40%. It's got a risk factor of of a pre-morbid depression in terms of diagnosis and poor socioeconomic circumstances. And there is this link also between just having this immediate suicidality. So it doesn't even have to be accompanied by a depressed mood. You can just have this, sudden feeling that you are suicidal. And there is this link between traumatic brain injury and there's this 4-time greater risk of attempted suicide and traumatic brain injury with loss of consciousness. So it is there and it is a symptom that you must screen for, even if somebody says my mood is not depressed. Mood disorders, post TBI, especially depression, can manifest differently from a non-traumatic brain injury patient. I think that's very important that it doesn't necessarily have to be this clear, I'm feeling guilty, I don't want to eat, I have no energy, and I'm, very depressed. It can sometimes come across as this hostile frustration and irritability, and the sadness is kind of masked by that. They can be sometimes very unpleasant, and we've seen this in the clinic. The confounder can be a frontal lobe injury, which also presents with apathy, and you'd have to kind of be able to work that out in terms of the mood versus the definition of apathy. And in some of these studies, the patients were treated with a mood stabilizer and an antidepressant when they would have that kind of explosive anger and also the depression. As I said, mania is relatively uncommon. You end up having a situation where you can have contusions to the temporal lobe polar regions, and it causes this, quite unchecked mood. You must also differentiate between manic episodes and disinhibition, because in a frontal lobe syndrome, it's less goal-directed and not persistently elevated mood, and lithium is an option. Lithium does have some sort of also neuroprotective properties. You do have also these other changes in the behavior, emotionalism, where the patient can just, have this labile tearfulness and accompanied by a sense of sadness. We've seen I think it comes in also with regards to post the traumatic brain injury. If there was some sort of time where the patient's life was also in danger, that can also become, a part of that and play in terms of the psychological aspect. But it's important to distinguish it from major depressive disorder and emotional incontinence. And emotional incontinence is ultimately that handbrake, as I was speaking about, but between the frontal lobe and the bulbar nuclei. And what you can end up getting is this incongruent response without that congruent mood state. So patient could be laughing inappropriately, patient could also be just crying, but there's no congruent mood state. And we do treat that with fluoxetine, with dextromethorphan and quinidine. So you can use that if you do have a patient who has that. And then these are some of the things that unfortunately complicate, your ability to make that diagnosis of depression is apathy and abulia. And, they have different kind of definitions, but, ultimately they can be there. It may respond to, as I said, stimulants, but you'd have to be worried about some of the issues regarding the seizure threshold. So going on to psychosis, and this is always a very interesting one because psychosis post TBI, in my experience, is quite a difficult one to treat. It has this very difficult, it almost feels like a treatment-resistant schizophrenia. The thing that we always kind of speak around in psychiatry is it just a coincidental finding of schizophrenia in a patient with traumatic brain injury, or is it the psychosis a consequence of traumatic brain injury or seizure related? So there's, three aspects there, but what we find is that they have the similar delusions, hallucinations of somebody who has schizophrenia, but again, it's quite rare. You do have the psychotic symptoms often that are different from those seen in the general population. It's usually positive symptoms more frequently than the negative symptoms seen in schizophrenia. And just in terms of using your medication, you would use antipsychotics in these patients in terms of this frank psychosis. But there has been some literature on using a mood stabilizer to help control if there is this kind of blend of psychosis and mania or aggression. So you would be able to use both of them. So that is seen in the literature. A big aspect of traumatic brain injury, and you can understand, is going to be anxiety and post-traumatic stress disorders. You can have generalized anxiety disorder. Just highlighting post-traumatic stress disorder because, of course, anybody who's in a traumatic brain injury, there is a high likely well, there's a likely chance that they were in danger or their lives were put in danger. And what happens is that one of the interesting bits just to highlight on for everyone here is they started to ask the research, can you actually have a post-traumatic stress response if you can't remember the trauma? And there's quite a few interesting theories that have come out, and the research has shown that a lot of people, despite not having that memory, do have post-traumatic stress responses and even some of the autonomic hyperarousal. So it's almost kind of built into us to have when something when traumatic happens, despite us not remembering it, it's already following almost an innate process. So what they see is that PTSD can follow mild TBI and even severe TBI, and you can have this thing where the trauma does come back despite having the amnesia. So there are some theories just to go through it. It's one of the models that they discuss is fear conditioning, and it's just the fact that you're still having the sympathetic arousal. And it's supported by animal models who, in terms of this overconsolidation of trauma memories, and they seem that ultimately the body just has this response despite the fact that they can't remember. Another theory is that as the traumatic brain injury patient reconstructs the trauma memories, despite having that impaired consciousness, they start to kind of remember bits of it at a time. And then based on police reports and dreams and other secondary sources, that's where the traumatic event starts to kind of, build some sort of it builds some sort of almost severity, and you're looking at the fact that the PTSD episode can occur. And then a third possible mechanism is that, for example, the amnesia does at some point come back. Does resolve, sorry, and you start to have a clear memory of what's been going on. And unfortunately, that's when the patients start to have those flashbacks. For example, somebody who's been cut out of a car with the jaws of life, or they were knocked unconscious in an MVA, and even the pain memory can start to come back, and that's what triggers the post-traumatic stress disorder episode. So some interesting stuff around and research around that. A major issue that we see in our clinic is that comorbid substance use disorder, which complicates our treatment plan, which complicates also the patient's rehabilitation and their almost commitment and motivation to a treatment plan. And alcohol being one of the most common ones, and cannabis in our population. And there's a 22% prevalence in TBI versus a 15% lifetime prevalence in the general population, and it's strongly associated with having a pre-morbid substance use, and that's quite clear. Going on to the cognition, and I think this is something that we don't focus on too much with regards to traumatic brain injury, and that's where neuropsychiatry does come in and help patients. And working within a multidisciplinary team with a neuropsychologist, an occupational therapist, and a social worker also kind of guiding the families, we're able to bring all of this information together and allow the patient to almost have a cognitive rehab plan. So you do have these different forms of cognitive deficits in a traumatic brain injury. You can have the clear amnesias, uh, anterograde and retrograde amnesia, which usually shrinks over time. And unfortunately, sometimes the neurocognitive deficits, you've got to give them, up to a year, even up to 3 years, until you kind of can say that, okay, this is maybe the patient's new baseline, hoping that they recover as much of that cognitive deficit as possible because of the acute injury. What we do see is that there's quite a clear slowed information processing speed, and there's poor attention, poor concentration, poor short-term memory, an impaired ability to plan, organize, and decrease abstract thinking. It's almost forming that of a subcortical kind of process, a subcortical illness, in the sense that all those cognitive domains are linked to more of the roads that connect the different lobes. And you think about the fact that that axonal injury is happening. That's what we find. But you obviously also can get focal injuries to specific lobes, and then have quite a clear kind of or like an aphasia or an apraxia. So that also does happen. And patients also have CVAs, post-traumatic brain injuries, and it just complicates things further. One symptom that is very interesting is anosognosia, and it's just that failure to appreciate the severity of the deficit or even its existence. And even the patient that came in, who I was mentioning, that he was a rapper, and he ended up not being able to actually appreciate that he was behaving in an unempathic way to his family. So this is a bit of a concern, that patients are walking around not being able to acknowledge those deficits, and it also obviously affects their quality of life and their interaction with everyone. So it is a bit different from denial, which is often characterized by that angry protest when confronted. So collateral is important or asking the family to be able to just check on that symptom. So it may persist after the delirium is resolved, as I mentioned. It may include hemiplegia as well as movement disorders. So as I said, this is where the injury may occur. And as I said, aphasias and apraxias are particularly common, depending on the location of the injury. So you can get quite a widespread amount of cognitive deficits. We've mentioned that they're less impressive after 12 months, and you've got to give it time. Unfortunately, they don't show any clear effect by using some of our drugs that we use in Alzheimer's and vascular dementias. It can actually have a reverse effect. You can increase aggression. So you do look at maybe using some of our neurorehabilitation and being able to stagger that rehabilitation so that the patient is able to return to some sort of function. Um, so I would say this, that it is a risk factor for dementia. It is clearly there in the Lancet study that traumatic brain injury does pose a risk factor for a neurocognitive disorder. But it's just important to also note that the cognitive symptoms that are post the actual traumatic brain injury are more likely due to the structural changes and the damage. There's quite a clear distinction between a neurocognitive disorder and the traumatic brain injury cognitive deficit. So that can sometimes be confusing. Now, this is just out of interest. I wanted to mention chronic traumatic encephalopathy. As I said, we've got a lot of sport in our country, and it's becoming more and more topical because we've been hearing a lot in the media around, patients who have or sportsmen that have now ended up developing motor neuron disease, and also studies showing that this kind of repetitive concussive episode ends up causing what we see almost as a neurodegenerative illness or a neurocognitive disorder. So there are its old term was dementia pugilistica in terms of the boxes, and similarities between Alzheimer's disease and chronic traumatic encephalopathy. It's speculation that they do share some sort of similar genetic risk factors, especially through that ApoE4 allele, which may be involved in the inhibition of neuronal growth following brain injury. And there are some other psychosocial factors. Age at which you first started playing and using performance-enhancing drugs may influence neurodegeneration. But again, it is a very, in terms of the research, when you look at chronic traumatic encephalopathy, there's not much, and I'll go into it, but there's not a lot of clear kind of ways to define it in terms of the criteria. So it does become a bit confusing in that sense. And, I guess that will be part of the discussion. It has led to a bit of confusion because the terminology, as I said, it gets thrown around between the Americans and the international groups. So traumatic brain injury and concussion are often defined based on the time course of post-concussive symptoms. The terms mild traumatic brain injury and concussion are used somewhat interchangeably without clear distinction, with concussion often being preferred by the sports community and mild traumatic brain injury by the medical community as discussed. Um, and then concussion is defined as a clinical syndrome of impaired brain function, typically impacting memory and orientation. So as you can see, similar to a mild traumatic brain injury, it's with or without loss of consciousness that results from some type of impact to the head. So I guess the difference would be this can be without a loss of consciousness compared to mild traumatic brain injury. Post-concussive syndrome, though, syndrome is different. It's a constellation of clinical signs and symptoms that may remain for weeks, months, or years. So chronic traumatic encephalopathy is leading towards this neurodegenerative change. Post-concussive syndrome, I'll discuss it in the next little bit here. I just want to check the time. We're still okay. So chronic traumatic brain injury should not be confused with PCS that may result from a symptomatic head injury. Chronic traumatic encephalopathy is a separate a long-term consequence of concussive and subconcussive repetitive head impact. So you have to have that repetitive head injury in order for you to be able to start to come to the definition of it. And they've also seen that asymptomatic subconcussive impacts are associated with CTE. So this is just giving you the history of what's been happening in terms of it. I'm not going to go too much into it, but this was part of, just for theory. Because of our love of sports in our country, and a lot of the data is obviously from the US. I'm sure we are going to start looking at it. If you look at even some of the studies from the Italian footballers, I think it was in the early 90s or late 80s, they have this issue with regards to from hitting the ball at the soccer ball at such high speeds. They started to also look at this relationship between neurodegeneration later on in life and also motor neuron disease. What we're seeing now is that we have athletes. For example, there was an English Rugby World Cup winner from, I think it was the year 2003, and he can't even remember the game. He's already on his way in terms of that memory impairment and that neurodegeneration. So there are major concerns about how do we protect this group of people in terms of for their career and also their livelihood, because this is quite a clear link between the sustained mild TBI or repetitive concussion developing chronic traumatic encephalopathy. So that's what the research says. But I will show you something that is a little bit of interest. That kind of maybe debunks a lot of this and makes us think what else could be going on here. So the NINS criteria are there in terms of trying to develop this what's happening in terms of pathophysiologically. There is axonal injury, microhemorrhage with subsequent loss of the blood-brain barrier integrity. There's inflammation cascade, deposition of both tau protein and neurofibrillary tangles. So you can see that relationship between this and Alzheimer's. And it's, something that would be considered tauopathy along with Alzheimer's disease and other neurodegenerative conditions. So macroscopically, you see this diffuse atrophy of the brain. The shrinkage is there. It's in the cerebral cortex, the mammillary bodies, which are very integral to our memory circuits too, corpus callosum, thalamus, which is our relay station, brainstem, and cerebellum. And there's other parts of the brain that are there to be specific for CTE. But the one thing is that they did see the history of repetitive brain injury you do see findings, pathological findings in CT in those patients, and none in 198 brains where there wasn't this history. So there is this clear link um, that they're trying to put together. So they do find that there's a rate of progression between any two successive pathological stages of CT estimated to be 11 to 14. And it appears that the older presentation of disease is more aggressive versus the younger onset. It seems to have this progressive clinical course similar to other degenerative illnesses, as I said. The only issue here is, and this is what I was bringing up, is that definitive diagnosis CTE in a living person is not yet possible, of course, and there's no gold, well, the gold standard is, post-mortem. Importantly, the research criteria don't combine the clinical syndromes being reported with the definite pathologically proven CTE. So that's a bit of a concern. Just to give you an idea of the evaluation of CTE, the history should focus on the history of repetitive head trauma. This is where we come in because you start to see a very clear neurobehavioral symptom associated with CTE, and the time course of decline in behavioral and cognition is also there, and it's quite specific to CTE. And you can also get other signs, upper motor neuron signs and fasciculations that are associated with motor neuron disease and Parkinson's. And the one thing that they do have is, this physically violent and verbally violent issue, and these impulse control issues, and leads to sometimes legal consequences. And I'm just going to show you that the memory impairment's at the top. And this was an American wrestler who ended up murdering his family and his children. And a lot of it was attributed to chronic traumatic encephalopathy. Muhammad Ali, it's quite clear his neurologist says that he had Alzheimer's, but a lot of people had speculated he had chronic traumatic encephalopathy. But I think his name is Chris Benoit, but ultimately he had this episode, and a lot of people couldn't understand why he ended up doing something like this. And it was attributed to these explosive episodes from this repetitive trauma to his brain. So we said that the cognitive profile of CTE involves impaired memory and executive functioning. They also have problems with concentration, judgment, and problem solving. And it may lead to, as I said, substance abuse, bankruptcy, and failed relationships. So it's something to keep in mind. And it has this link to frontotemporal dementia and motor neuron disease via quite a big genetic marker, this open reading frame 72C9. And what we see is that they do have more memory as compared to behavioral variant FTD, which is a frontotemporal dementia. These are some of the ways just to distinguish the two. I'm just going to go into the symptomatic treatment. There's no medication, unfortunately, approved by the FDA for CTE. So we're using a lot of off-label trials of things in terms of, NMDA antagonists, and for attentional issues, you rarely ever use atypical antipsychotics. We did have one in the case in the clinic at some point, and we'd managed to do a post-mortem. He was a boxer, so it was quite a big thing in terms of, and it has been written up. It's by Dr. Sabanze, who used to work at our clinic. The one thing just to bring out here, and I don't want to, just for time's sake, I don't want to focus too much else on the slide, except for the problem with a lot of these studies that looked at these athletes is they didn't control for the fact that a lot of these, well, this is the third point, a lot of these athletes, in terms of their pre-morbid functioning and comorbid factors, which would normally affect cognitive reserve, were not controlled for. So it almost begs the question of, if you're not controlling for that, were these athletes going to develop some sort of neurodegenerative illness anyway? And that's what I was trying to say right from the beginning, is the problem with some of the CTE studies is that this could have been the expected outcome anyway. Maybe it's just coincidental that they have been, athletes, and they've been having repetitive concussions. Look, I mean, the evidence is pointing obviously more towards the fact that they are having the repetitive trauma and it's causing an issue. But in these studies, unfortunately, a lot of that hasn't been controlled for. And a lot of the actual educational level, that was one of the big things that they mentioned, because unfortunately, a lot of the athletes do focus more on the sport and less on the academic side of things. And that was something that was brought up in one of the articles that was mentioned. So going on to post-concussive syndrome, and I'm going to just look at some of the aspects behaviorally of this, and I want the take-home message to be that this is something that can be clearly avoided if, as a clinician, we're able to sit with the patient and we're able to discuss all the different symptoms that happen post a traumatic brain injury. Post-concussion is a very strange period because the patient experiences multiple physical, psychological, physiological changes, which I'm going to get into. So it's most often seen in prolonged mild traumatic brain injury, and most patients will have a spontaneous resolution of the symptoms, but it can linger, and that's where we start to see the health system taking strain, especially with some of these patients. So, as I said, it's a constellation of all these different symptoms. It can really vary, and you can see that it can sometimes blur the lines of multiple diagnoses. I mean, headache, fatigue, vision changes, disturbances of balances, confusion, dizziness, insomnia. You can imagine if somebody comes into your, clinical room and they sort of say all these symptoms, you just wonder, how am I going to help this patient? And this is where these patients can be quite difficult. Where it starts to become a problem, as I said, is when it starts to persist past 3 to 6 months, and then it starts to become almost a treatment-resistant issue. And this is where you have to mobilize a team in order to use, our multidisciplinary team to be able to address all of these symptoms and to almost help the patient like how you would help a functional neurological disorder patient. So it's very important that you address all the symptoms right from the word go, or otherwise these symptoms linger. And I wanted to also show you that it can have lasting effects on cognition, memory, learning, and executive functioning. For patients who suffer more than one brain injury are at increased risk for post-concussive syndrome. And we have an underestimation of the true incidence of post-concussive syndrome because it's something that you have to look at. I wanted to also just say on this slide here that you do have issues regarding, especially complicated mild TBI. It comprises symptoms of a concussion with associated head CT and in terms of abnormalities, a hematoma. So it can end up becoming an issue compared to somebody who's got a normal head CT scan or uncomplicated mild TBI. So as soon as you have a complication, it's more likely to have an issue regarding a progression to post-concussive syndrome. Patients with uncomplicated mild TBI are more likely to have resolution. So as I said to you, the more severe this thing is, the more chance you have of having this progression to post-concussive syndrome. What we do see in the epidemiology is that there's two clinical criteria to diagnose from DSM-4. It didn't really translate into DSM-5, especially when applied, giving varying results. The previous reports and literature have attempted to associate the severity of the brain injury with PCS in patients who have suffered mild TBI. However, these have failed to consistently report that the severity of injury correlates with the risk of PCS. And the one thing is that there is evidence, at least one research study suggesting that medical history of recent or multiple prior concussion episodes is an associated risk factor for the development of prolonged symptoms of concussion. So even here, it's a little bit divided as to whether the severity is a clear indicator or not. Women are at greater risk for persistent PCS. They're more likely to endorse a headache, irritability, fatigue, and concentration problems. And there's increases in age, which are also associated with a higher risk of PCS. Minors are thought to less likely experience PCS due to the neuroplasticity. They have a greater neuroplasticity. In terms of the pathophysiology, it's that combination of metabolic, physiological, and microstructural injuries that happen to the brain. They've also said that there could be a psychogenic origin in nature. And I must say, in our experience, we have seen that. We've seen how, as I said, this functional component almost comes in. And when I just briefly go through this case, I just wanted to show you what this patient presented with so that you can see. And then you do have this autonomic nervous system involvement. But essentially, the patient's got these abnormal illness beliefs that can sometimes come into play. If they in their childhood they had predisposing factors and a poor understanding in terms of attachment to the caregiver and just a poor understanding of how to relate to illness, and attention to the symptoms becomes hyper-focused. They also sometimes lack the emotional processing and the words to be able to describe the symptom and what's going on in their internal state. And they also lack the agency to control their illness. And this all becomes a perfect blend for, unfortunately, a disaster when the post-concussive syndrome goes on for more than 6 months. This is just in terms of those symptoms that I mentioned. The management, usually it's self-limiting and does not progress to PCS in 85 to 90%. What they say is you must ensure rest. you should be symptom-free before usual activity. But simple reassurance is often the major treatment, and giving that support in terms of, from and the psychoeducation and the psychotherapeutic support is very important. But they do have some mention of medications that can be used. They speak around exercise if you're looking at non-farm, low level, that they recover a bit faster. But again, it's a major team effort, especially when it starts to move over into post-concussive syndrome, that where the symptoms, all the dizziness and fatigue and stuff lingers. And that's where we're well poised with our MDT and the neuropsychiatrist to treat these patients. So you can see the differential diagnosis is quite exhaustive because all these symptoms overlap. And it's very difficult sometimes to be able to distinguish if there's comorbidity also or one or the other. The prognosis, as I said, is generally good, but you want that resolution of the symptoms to happen. Where we always say this, that where it starts to become months to years and there's quite prominent emotional symptoms, also look into the fact, is there any sort of secondary gain, and what is, with regards to litigation, we always see that RAF form sometimes popping up, and then we start to get a bit worried because there is some sort of investment in the sick role. So this was just to show diffuse axonal injury in terms of, on a scan itself. But I wanted to just go through this briefly. It was a 51-year-old male who came through to the neuropsychiatric clinic at Barra. And what had happened was he was working before, and then he was involved in an MVA passenger rapid acceleration deceleration situation, and he sustained traumatic brain injury, moderate in nature. He was supine in the seat and was blunt force trauma. There was no CT scan and only a clinic review on the day with the L-spine X-ray. The problem was he presented quite late to us. So by the time he had gone through the healthcare system, and it felt almost a little bit like it hadn't been handled quite well in terms of from an empathic point of view and just in terms of listening to some of these symptoms. So by the time we got him, he'd already gotten past almost that 6-month period of post-concussive syndrome symptoms. But he was also having this increased aggression, frustration tolerance was poor, socially withdrawn. He was having some of those neurological symptoms that I mentioned in terms of when I first started the presentation, and he had working memory and attention impaired, but he was also depressed. He had this issue with his mood. He had chronic lumbar backache, loss of visual acuity, hemorrhoids, erectile dysfunction. He had post-traumatic stress disorder symptoms. Insomnia was initial, and decreased mood, as I said, with decreased libido, decreased energy. He had some of those symptoms. He didn't really have ictal symptoms. It was something that was he felt was there. They do have sometimes that shearing of the olfactory nerve, and it did recover with time. Look, the issue with this patient, and just to point out, is that unfortunately not every patient is a success story. This patient ended up struggling with regards to those post-concussive syndrome symptoms, and ended up actually leaving the clinic despite all the interventions. There was definitely a loss of agency and investment in the sick role. He wasn't committing to a treatment plan. And as I said, it's just to point out to you that these patients exist, and it's very sad what they go through because in a way you almost feel like you failed him regarding the health system. But you just hope that he's managed to get some help. But it is a real struggle. And look, he had all the cognitive issues. We did some bedside screening, and despite giving him the kind of therapy, especially from a neuropsychologist that we had at the clinic, he wasn't able to reconcile that loss of function that he had, and and the actual quality of life had started to deteriorate, especially the relationship with his wife. So, as I said to you, when that emotional symptom persists, we started to see a little bit more of this, almost like a functional neurological disorder, and we weren't able to help him any further because he was quite resistant to the treatment plan. And yeah, this was just his diagnostic formulation, and just some of the medications that we used. We stopped the risperidone because that had been started, and we tried to change him to a new antidepressant with an SNRI. We also tried to just clean up his medication. We tried to treat everything that he had been going through. He didn't bring up any psycholegal issues, but ultimately, as we kept on trying to refer him to all the different departments to get the help that he needed, he kept on, defaulting in terms of those appointments. And we do believe that a lot of his, condition can be attributed to, as I said, there was that hyper focus on the symptoms. He was unable to kind of have the emotional processing, a lot of pre-morbid issues, and it just ended up becoming difficult for him. So I just want to say thank you to Dr. Nashaple. She did guide me through a lot of her lectures in terms of traumatic brain injury, and I've been able to at least use some of her references. But these are some of the things that came up in terms of the research. There are references, and thank you very much for listening. Sorry it was a bit long, but I just wanted to give you all the information that we currently have on the topic at the moment. Thanks.
Thank you very much, Dr. Miseer. No, it wasn't too long at all. I think it was just appropriate. We've been so glued onto your lecture. I think this was very educative. I think you can see all the hearts and the applause on the screen from our audience. I think they really appreciated it. We had I think 413 people listening at one stage. I think they've been so glued in that they even didn't have time into your lecture, concentrating that they didn't have time to write in the chat box any questions or comments so far. They just want to, but I think is that you can just raise your electronic hand if you'd like to make any comment or ask Dr. Miseer any question. You can also, of course, type in the chat box, and then we will check your question, and we will come back to Dr. Miseer will respond to your comments and questions. I think for me, and I'm sure I'm speaking to a lot of our colleagues, this was a lecture out of the ordinary. We learned so much about the effects of trauma on the brain. I mean, you spoke about early presentations and early symptoms up to the first 7 days, but it may take years for symptoms of TBI to traumatic brain injury to manifest themselves, which is scary. So really, we don't know, whether all the mental health that we see in our country, Dr. Miseer, I think you'll agree that mental health is a problem currently in our country, and it's on the rise. Our hospitals get full of mental health care patients. Could that be related to the abnormally high rate of trauma in our country? After your talk today, is there a link between the rise in mental health, because traumatic brain injury seems to be able to cause almost any of the symptoms and signs of so many other mental health care syndromes. Would they be related to trauma?
Thanks, Dr. Kuroshi. I think the one way I could see the relationship existing is a lot of our mental health care users are vulnerable, especially when they're not well. Their behavior can be misinterpreted as, that they are violent, or that, and somebody who's not informed is going to, consider assaulting a mental health care user. And that's what I think is an important message. Everybody always takes the side of a mental health care user as inherently violent and aggressive. It's actually that they sustain more aggression towards them. So I think the one thing I would say is that whenever you are sitting with somebody who's a mental health care user, always be careful to screen for traumatic brain injury. And it is part of our, psychiatry clock, because you want to be able just to make sure you're ruling out a significant traumatic brain injury that could be having some sort of effect on their cognition or on their neurobehavioral presentation. So I think that would be the link, the relationship behind it. Yeah.
Okay, that's scary. Dr. Muhyiddin Khan asked a question: would frontal lobe apathetic disorder manifest with unrecognized history of injury? I think related to exactly what you just said. Maybe you want to respond specifically to Dr. Khan?
Look, I mean, the thing is that you sometimes have to be a little bit aware of somebody's pre-morbid functioning, and I think that's where you'd have to bring in the family. If I'm getting the question correct, in the sense that you are sitting with somebody who's apathetic, but you're not suspecting a head injury. Always when somebody comes in, you've got to look at what they were doing before this, what was their kind of personality before this, discussing that with the family. And then once you understand what the premorbid function is, you're able to then, investigate further as to what exactly could have been the cause of it. So yes, there could be a lot of, I can understand there could be a lot of people who are not really presenting uh, well, after having a significant head injury. But I think when they have that change in their personality, it's very important to investigate further. Or otherwise, you're not going to be able to get to the root cause of why this person has had this change. Yeah.
Okay, thank you. And there's a question from Dr. Valencia Pateri.
Yes.
The question is, in pre-existing bipolar with subsequent substance abuse, how would one approach a TBI with prominent neurological symptoms?
Okay.
I don't know whether you can see the, you can see the questions.
Yeah,
in
I
the,
can see it. I can see it. Yeah.
Yeah.
I just to clarify, I mean, when you're asking around an approach for neurological symptoms, look, a patient with pre-existing bipolar disorder and even with substance use, they're going to be controlled on their medication, and they're going to have their mood stabilize on their medication, and they would have obviously had a team effort in order to address the dual diagnosis of the mental illness and also the substance use. So, with regards to approaching them, you would approach them like how you would any other patient, in terms of that neurological history and examination. Um, so I don't think there's much of a difference in terms of between somebody who has no pre-existing mental illness and somebody who's just a patient who's come in with a traumatic brain injury. You would still have the exact same assessment as I mentioned in the slides. You would go through your formal neurological symptoms, neurocognitive and neurobehavioral. Yeah.
That's right. I think Dr. Joy Nkuna asks the question. Well, first of all, he says, good evening. Thank you very much for a great presentation. Very informative. Would the symptoms and presentation be the same with patients that have had a craniotomy? And I suppose that depends on what the craniotomy was for. Yeah.
Was for, yeah. Look, I mean, in terms of if I'm interpreting the question correctly, if it's a controlled procedure, I mean, we would hope that there's going to be no injury, in terms of if it's but the point is, as you said, what's the reason for the craniotomy? Is it post-injury? Is it, a tumor that's developed, a brain tumor? So we do see that, unfortunately, just when I think about a craniotomy, we at Barrow we used to encounter a lot of patients that had had brain tumors, and the neuropsychological team was involved in what was the cognition post the brain tumor removal. So they'd assess the patient before the brain tumor removal and then post craniotomy, and to show that the surgery was successful and there weren't any deficits that were new. So the thing is that I think a lot of it, as you said, has to deal with what was the reason for the craniotomy. But depending again on where the injury is and where the actual, kind of functional and anatomical area has been affected, then you are going to have essentially the same symptoms. Depending on obviously an intracranial pressure increase, you can have almost this atypical, depressive symptom presentation, because that whole brain is kind of being sustained under a lot of pressure. So you do see these patients having issues with regards to their ARAS system, which is essentially your attention, but being affected, and they fluctuate. But yeah, I would say again, a lot of it has got to do. It's going to be where that area is an issue. That's going to be the resultant symptom. Yeah.
Yeah, Dr. Zuki Swapinini, good evening, Doctor. Is asking, well, first of all, just thank you, Dr. Prinesh, for the informative presentation. Could you please share the presentation with us? Yeah, our principle, before you answer, and Dr. Miseer, yes. Our principle with these webinars has been that we don't share the presentations generally with respecting the presenters, but attendees may request a copy of the presentation, maybe in PDF, from us, and then we request the presenter. And if the presenter says yes, then we email it to you. So we don't share it with everyone who attended, but you may request formally, and then we will ask Dr. Miseer, and some of the speakers say yes, others say no. I think they are free to do so. You can just write to us at webinars@clinix.co.za, webinars@clinix.co.za, and if Dr. Miseer agrees, then we will send it to you. Dr. Miseer, would you agree with that principle? It's just a principle that we
I think that's a good principle. Yeah, we can deal with it on a case by case. Yeah,
case by case. So Dr. Pinini, I hope I've answered you. Webinars@clinix.co.za. Sam, you can put it on the screen. Our email address. For anyone who'd like to ask us anything, by the way, you may go on to use that, webinars@clinix.co.za. I saw one other question. I think there are more people who are asking about the presentation, so we've answered that. But there was one asking about, okay, that's Dr. Rataimani, Dr. Solis, Dr. Mani is your colleague. You probably know Dr. Rataimani very well. He says, are there any rating scales that can help to determine the exact syndrome? You mentioned quite a number of syndromes in your lecture. Are there any rating scales that can help determine which one is which?
Look, I'm not aware of any specific rating scales for frontal lobe syndromes, but I am sure that there are rating scales for, in terms of to determine the severity of apathy, or, for example, with even something like a bedside screening test, like a frontal assessment battery. Yes, we do use it to distinguish between Alzheimer's disease and frontotemporal dementia, but it can also be used to kind of expose some of those symptoms of a frontal lobe syndrome. As I said, I'm not going to be able to say if there's an exact scale because I'm not aware of anything like that. But from my understanding, though those syndromes have always been of more on a clinical diagnosis in terms of the patient that's in front of you, and then the bedside screening tools that we use show either this dysexecutive presentation, or in terms of clinically you can see that the patient is aggressive or disinhibited, or they're apathetic. So as I said, I wouldn't know if there's any exact scales, but that was always my impression of whenever we're discussing frontal lobe syndromes, that it's a blend of our history exam and our bedside screening tools. Yeah.
What you've learned in the last few years as a psychiatry specialist, and what you've taught, you shared with us today. What is your attitude towards sports, so-called sports, I must say, like boxing and its many modern variations, which are just so brutal? Well, maybe that includes rugby as well, because we get a lot of concussions in rugby as well. What is your attitude? What would be your advice to young fathers and mothers regarding their children playing those games?
Well, look, I think that, well, first of all, I love sports, and I love even boxing and rugby. So the thing is that it's going to be a biased answer. So I think the main thing here, though, is that if we are already seeing through the research that there are these concerns regarding brain health, the future of your brain health, if you're having repetitive concussions or any hit, even concussions that are asymptomatic, you're having these blows to the head, we should be having the authorities or the ruling bodies of these sporting codes to be able to start to create policy as to how they can start to protect and to donate more into research to actually see how they can protect these brains. Because I mean, look at what I was even mentioning about the wrestler. I mean, the subsequent complications of his career had led to him murdering. It was a murder-suicide of himself and his family. So it's a public health concern, especially our rugby players. I mean, the game has become, um, faster. We can even see that the players are bigger, better nutrition, better physical training, and it's become at a point where, yes, they are doing things to mitigate it. Like if anybody has an on-field head injury, they pull them off immediately. But I think, we need to see more, because we are seeing clearly from the research that there have been these issues with regards to motor neuron disease. Even US van der Vestes, and I think there was another English rugby player who got diagnosed with it. There's a clear link here, and we need to mitigate for that. Yeah.
And it's a pity we can't see Muhammad Ali being interviewed on TV these days. Until, if he didn't have what the condition he has, we would be enjoying hearing from him how he feels about all this, about life in general. But we can't. Just the last question. You said that chronic traumatic encephalopathy, CTE, cannot currently be definitely diagnosed during life, and it can only be done post-mortem, as opposed when you histology of the brain. With modern radiological imaging, MRI, sonars, it still cannot be diagnosed.
Yeah. I mean, unfortunately, yeah, even when they've done, functional imaging in terms of those SPECT scans or PET scans, through what we've seen in the kind of limited cases that they've taken of patients who, have this presentation and this repetitive trauma, is that unfortunately the changes in each of their brains is not, specific. They find that they have a heterogeneous kind of change in their brain. So you can't almost say like this specifically is to or almost use it as a biomarker essentially. So that's the concern with regards to chronic traumatic encephalopathy, that despite all the imaging that we have access to, they haven't been able to find a uniform kind of diagnostic marker for it, even on the scan. So maybe in time we are going to be able to find some sort of biomarker for it. But right now, I mean, again, it's a definitive diagnosis, and that goes for most of even our neurodegenerative illnesses. I mean, everything ultimately, Alzheimer's, all of them are. We even say in our criteria, diagnostic criteria, possible and probable. We can never say clearly 100%. It's always that almost proviso. So you always need kind of a biopsy in order to make sure, unfortunately, right now for a lot of illnesses. Yeah.
If anyone else has any questions, even if it's tomorrow or whatever, and you'd like to ask Dr. Miseer any question or comment, you may still send it to us on webinars@clinix.co.za, and we will pass it on to Dr. Miseer. I think at this stage, I'm going to ask one of my colleagues, our Chief Medical Officer, Dr. Burton Shinas, just to do a vote of thanks for us. And any comments you'd like to make? Dr. Shinas, over to you.
Thank you very much, Dr. Kinoshi, and good evening to you, Dr. Miseer, and to our colleagues who are attending this evening. Before I give all the praise and accolades to Dr. Miseer, first want to just bring to the attention of our colleagues, a number of weeks ago, we called upon you to nominate and motivate for some of your colleagues who you felt were worthy recipients of the South African Health Excellence Awards. So I want to say thank you to you that who put your colleagues' names in the hat, and for being so consistent and being so elaborate with your motivation of your colleagues to receive these awards. So we want to say thank you so very much. As a reminder, the South African Health Excellence Awards are taking place next week, Saturday, which is going to be the 8th of November. So, Dr. Miseer, you were so thorough. I thought you were feeling a little bit anxious and rushed, but really it was remarkable, and you can see so many of our colleagues remain on the line to listen to some of the answers to questions that everybody poses. Most certainly learned so much, and I was watching that movie, the Will Smith movie, the one where it's concussion, right? So where he's a
Concussion.
pathologist. Yeah, yeah, exactly. Concussion. And he indicates there that, as you pointed out as well, the gold standard diagnosis, unfortunately, is a post-mortem to
Mm,
determine that. So, as Dr. Kinoshi said, I mean, that was from what's it, American football. And in South Africa, are you seeing this happen from any of the sports that we're picking up? I know we are a big rugby-loving nation, and we're always
mm,
supporting that. Are you seeing any trends of any kind for children or even our professionals coming through? I know you mentioned US van der Stezen. Uh,
mm, mm.
yeah. But I'm seeing all these
Uh,
forwards flashing all the time, right? Every time there's a scrum, and this happens for
yeah.
years. Yeah.
Mm. Look, maybe we're just blessed as South Africans that we're just stronger. We don't. No, look, I think I think the problem is that we've struggled with regards to getting the research mobilized, and I stand to be corrected. Maybe there is something that's ongoing at the moment. We do have a sports psychiatry special interest group in SASAP, our Society of Psychiatrists. And maybe these guys are taking on that kind of endeavor because it's a very controversial topic, especially CTE, in
Mm.
terms of in rugby, because I mean you can understand that there's a lot at stake if somebody has to prove that look, this sport causes a neurodegenerative process, and you got to have all your facts straight before you come in with that kind of thing. So I think that's something that needs to be investigated and to help these players because that's their livelihood, and they need to be compensated properly if that is the case.
And we love sport in our country. And the rugby loving nation too. Dr. Miseer, thank you so much for the effort in putting everything together. And please do thank your family for allowing you to spend some time with us. I know you are making a sacrifice, not only in terms of presenting this evening, but also preparing, putting the presentation together and making sure that you are entertaining, bringing live examples and something that we could all relate to and just making sure that we have a high level of suspicion when we are working with patients going forward. Because I think you don't always consider that and just look
Mm.
at it from our standard level of training. So thank you very much for taking the time to spending here with
Yep.
us. And in the background, our colleagues, there is Tolagele, there's Sam, Viwe, the marketing team at Clinix Health. And thank you so very much to Clinix for putting the presentation together and sponsoring it week after week. And so we also look forward to the colleagues joining us next week. There's another fascinating presentation that will be taking place, which is going to be no doubt keeping you all glued to your seats. And we look forward to seeing you there. Dr. Kinoshi, thank you once more. And I look forward to seeing you all next week. Thank you very much, colleagues.
Thank you.
Thank you
Thanks,
very
Dr.
much, Dr. Dakshinas, and I think we will see all our colleagues next week, Thursday again. We will send out a notification in the next 2 days of the webinar next week. We will have webinars until, I think the last one is the 4th, the first weekend, let me say the first Thursday of December will be our last one for this year. But thank you very much, everyone. Till we see you next week, Thursday, God bless.
Thank you. Bye-bye.
Thank you, bye.